Hi, my name is Angie Stapleton. I'm a registered nurse at Altoona Regional, and my evidence-based paper was on patient safety and shift work. I'm evaluating how 12-hour shifts and overtime affects adverse outcomes and healthcare injuries to employees. Healthcare providers are not expected to make errors. However, mistakes occur, and some mistakes have resulted in serious injury or death. Shift work and extended shifts interfere with the body's natural circadian rhythm. The disruption in human nature's cycle enables adverse effects on patient outcomes and increases healthcare errors, patient injuries, and negative health effects of nurses. Mental and physical fatigues are the most common concerns associated with shift work and extended duration of shifts. Research supports that the prevalence of sleep-related motor vehicle crashes is higher among individuals who are employed and work more than 60 hours per week, work irregular hours, work at night, and are sleep deprived. Remaining awake for 19 consecutive hours slows reaction times and cognitive function to the level compared with a blood alcohol concentration of 0.05%, while remaining awake for 24 consecutive hours slows reaction times to the level approximating the times a person with a blood alcohol level of 0.1%, which is exceeding the legal standards for operating a motor vehicle. Studies focus on nurses who work traditional and rotating shifts, their ability to stay awake and remain vigilant, and the association between alertness and errors among nurses. Moving on to the background and clinical question. The current nursing shortage and healthcare errors has strained healthcare organizations across the United States. It is estimated 1.3 million healthcare errors occur each year, and of those, 48,000 to 98,000 result in death of the patient. The need for around-the-clock staff coverage has resulted in creative ways to maintain quality patient care, keep health errors or adverse events to a minimum, and still meet the needs of the organization. Organizations are decreasing staffing in regards to nurse-patient ratio, and nurses are working overtime, extended work shifts, or work weeks to prevent working short. Although these multiple working condition variables have been implemented to plug the gaps in nursing shifts in order to preserve patient care, there is a question at hand. Does nurse staffing, shift work, and extended work shifts in the hospital setting adversely affect nurses' health and patient outcomes? The purpose and design of this study is to determine if staffing, shift work, and extended work shifts adversely impact nurses' health and patient outcomes in the hospital setting. Although work shift variables fill scheduling holes and increase the number of days which nurses have at home with their families, long work hours and rotating shifts are provoking fatigue and decreasing vigilance. A descriptive correlation design will be utilized to examine errors contributing to poor patient outcomes in the hospital environment and their association with weariness and diminished awareness among nurses working rotating and extended work shifts. The data collection will then be used purposely to show a correlation of variables and reveal recommendations to minimize adverse effects among patients and nurses in the future evidence-based practice. In order to completely understand the purpose of the design, I thought it would be beneficial to give you a couple definitions. According to Simone Keller, who was an author of one of the articles I researched, extended work shifts can be defined as any system of fixed working hours more than 8 hours in duration, which results in working a work week of less than 5 full days of work, and overtime is described as hours worked exceeding the length of scheduled shift or regular 40-hour, 5-day work week. Shift work refers to the hours worked in which a relay of employees extends the period of production beyond the conventional daytime third of the 24-hour cycle. So I'm going to start going over some of the articles in which I used. The first one, limiting nurse overtime and promoting other good working conditions influences patient safety. The purpose of Sharp and Clancy's article was to support the theory of which good working conditions for nurses improves nurse satisfaction, patient safety, and patient outcomes. Sharp and Clancy draw on an observational research study that was performed by the U.S. Agency for Healthcare Research and Quality, which examined and analyzed if there was a link between working conditions and patient outcomes. The importance of this study on the nursing practice was to promote patient safety and nursing satisfaction with healthcare organizations. The Agency of Healthcare Researchers observed more than 15,000 elderly patients in ICUs at 31 hospitals and examined patient outcomes related to the quality of nursing care in regards to central line associated bloodstream infections, ventilator-acquired pneumonia, and catheter-associated urinary tract infections, decubitus, and 30-day mortality to investigate their theory. Researchers examined the number of hours worked, the time of day worked, overtime hours put in, their days off, and sleep patterns of 502 randomly selected critical care nurses over a 28-day period. Findings of this study showed that 65% of the nurses reported trouble staying awake or at least falling asleep once during the study period. 27% of the nurses reported making at least one error, and 58% of the errors involved administration of medications. The next article was effects of critical care nurses' work hours on vigilance and patient safety. The purpose of Scott and Rogers, Wang and Zong's article titled Effects of Critical Care Nurses' Work Hours on Vigilance and Patient Safety was to determine if an association exists between the occurrence of errors and hours worked by nurses and explore whether these hours work have adverse effects on the nurses' vigilance. The descriptive exploratory study examined the length of work shifts, the number of errors, and the frequency of episodes of sleep or drowsiness among critical care nurses who were members of the American Association of Critical Care Nurses. The particular group of critical care nurses maintained a full-time work status, providing direct patient care to critical care patients. Participating nurses logged their daily activities on and off the clock for 28 days. The logbooks were used to collect information about hours worked, overtime hours, days off, sleep and wake patterns, mood, and caffeine intake. Scheduled and actually worked shifts were commuted on a weekly and individual nurse level throughout the duration of the evaluation period. The findings of this study showed that although the number of errors was significant and the amount of overtime worked was excessive, the increase of error could not be linked to the decrease in vigilance. Results showed that an increase of crash rates by 9.1% of drivers who worked extended shifts compared to a baseline of 3.4% to 14.7% shows a linear relationship between fatigue and motor vehicle accidents. 6,017 work shifts indicated that the nurses worked longer than scheduled on a regular basis. 4,053 shifts, which is 67%, exceeded 12 hours, and 54 respondents, which is 10.8%, worked more than 16 hours at least once a week. During 1,203 nurses reported struggling to stay awake and actually falling asleep during 178 shifts. More than 20% of the nurses reported making at least one error, and more than one-third reported making at least one near error during the study period, which all resulted in a total of 224 errors and 350 near errors were reported by the respondents. Reporting errors consisted of medication errors, procedure errors, charting, and transcription mistakes. Some of the examples of the errors that they gave was a nurse gave digoxin to the wrong patient. They hung dobutamine instead of dopamine. Dosage calculations for a dopamine drip was misread milligrams for micrograms. Same for a prostostin drip. A major medical error was the patient received 12,500 bolus of heparin and the patient ended up going back to the emergency room. When using rapid infusers, they instilled air from blood product bags into a central line of a patient. And a patient just returned from the OR, restless, looking for an IV access on tubing, and different from an institutional norm, almost put morphine into an intracranial pressure drain. My third article was called Effects of Extended Work Shifts and Shift Work on Patient Safety, Productivity, and Employee Health. The purpose of this research article was to support the theory of which, although initiated as a strategy to decrease nursing shortage, extended work shifts and shift work generates poor patient outcomes, decreases productivity, and impairs employees' health. Keller's article addresses the effects of 10, and 12, and 6-hour shifts on employees in all professions. However, the impact on nursing is the magnet of her discussion. The importance of the study on nursing practice was to make public the harmful effects of extended work shifts and propose solutions in which would retain nurses while promoting patient safety and employee health. This article included a review of current literature on shift work, the definitions of shift work, error rates, and adverse outcomes related to shift work, health effects on shift workers, shift work effects on older workers, recommended optimal shift length, positive and negative effects of shift work on shift workers, hazards associated with driving after extended shifts, and implications for health nurses. The findings of this showed that the risk of an error almost doubled when nurses worked 12.5 or more consecutive hours. Nurses working shifts in excess of 8 hours reported more medication errors, difficulty staying awake and actually falling asleep during work hours, a decrease in productivity within the last 4 hours of their shift, and an increase in needle sticks and exposure to biological fluids during the last 2 hours of the 12-hour shift. My fourth article was called Nurse Staffing and Inpatient Hospital Mortality. The purpose of this article was to depict the association between patient mortality and patient exposure to nursing shifts during which staffing by RNs was at least 8 hours or more below the staffing target. The importance of this primary research article on nursing practice is to draw attention to patient mortality and the adverse patient outcomes in which occurs during hospitalization and reinforce the need to match staffing with patients' needs for nursing care. The data collected from a large tertiary academic medical center involved 197,961 admissions and 176,696 nursing shifts of 8 hours each in 43 hospital units was used to examine the association between mortality and patient exposure to nursing shifts during which staffing of RNs was 8 hours or more below the staffing target. The researchers used a Cox proportional hazard regression model to conduct a survey analysis from which the beginning of hospital admission to the time of in-hospital death had occurred. To measure the patient's exposure to high workload shifts, a normalized 8-hour block of time was designed as the measure to determine below target staffing and high turnover. The model included a start of shift census and a target staffing for the shift. The target staffing for RNs was consistent across days, evenings, and night shift. The findings of this research study showed results suggesting that both target and actual staffing should be adjusted to account for the demands of patient care required and the effect of the patient turnover. Staffing by RNs within 8 hours of a target level was 84% of the shifts. Patient turnovers was within 93% of the shifts.